Hello, Nursing 124 students. This is Dr. O'Shaughnessy, and I will be your lecture instructor for 8A for Nursing 124. Since tomorrow is a holiday with Martin Luther King, I just decided to tape a lecture and kind of point out the important information that I hope you get from the resources that I have provided you in your Canvas course. As you can see, the book that we use for dimensional analysis does have its own PowerPoints, and I have uploaded these in Canvas under week 1 for you. And we'll begin this course with looking at syringes and looking at the calibrations and being aware that there are different size syringes that we use depending on what the order is by our healthcare providers. And it's also important to understand and be able to read medication labels so that we continue the safe practice of administering medications to our patients. So up here, as you can see on the screen, I have Chapter 9, which entails reading medication labels and syringes. So I'm not going to go over this in complete detail. You have it now as a resource, and I would hope that you could do this on your own to kind of look at what information was pulled out of this chapter and then presented to you on a PowerPoint. It's kind of your own personal outline of the information from the chapter. These are just the objectives, which is always given on a PowerPoint to hopefully see if you've achieved this particular learning. It's very important that you understand the different sizes of syringes, because obviously the calibrations on that syringe are going to change whether or not a syringe is bigger or smaller. And it's important that you understand this because there will be some test questions that will ask you how much medication is a syringe depending on the size of that syringe. And what I would hope that you would do after reading this chapter and going over some of the practice problems is that you're able to select the correct dosage on an oral dosing cup or syringe, that you're able to identify the parts of a hypodermic syringe, and that you're able to calculate parental doses of medications and select the correct dosage on various types of hypodermic syringes. So for example, if a order of 1.5 milliliters of medication has to be administered in a syringe, maybe by a IM injection, you want to ask yourself, what size syringe would I use for that? We always want to use the smallest type of syringe to accommodate that amount of medication that has been ordered by the healthcare provider. So that's kind of what I want you to hopefully get out of this chapter. It's really nice with this particular book that you're able to kind of evaluate the learning by doing those practice problems at the end of the chapter. Medication labels and packages inserts contain a lot of information about a drug. They include all this information: the chemical composition, what disease or disorder the drug is used to treat, prescribing guidelines, really knowing those adverse drug reactions and interactions, warning and cautions about the use of the drug. And a nurse must be able to read and interpret this information in order to fulfill the 6 rights of safe medication administration. And remember, I want you to be aware that all the information that you learned in Nursing 123 should stick with you, because we are building on that information as we advance into more medications and more knowledge about the tools and the instruments that we use in administering the medications that are ordered for our patients. So again, you never want to lose that knowledge of what are those 6 rights of safe medication administration, because our goal is to be sure that our patients are safe with the meds that we are giving them. Okay, and it's our responsibility to make sure that we understand why that med is being given, understand the correct route, Am I administering it safely per that route? And what is it I want to see achieved when I give this patient the medication? Am I seeing the effects that hopefully the physician expects and that I as the nurse expect as well? And then what would I look for as far as some very minor to very serious adverse reactions that could happen when my patient is given this med, especially when we're giving it for the first time? And it is a lot of responsibility on our part, and it's important that we assess that adverse reaction as soon as possible, so that if there is an antidote or something we can do to minimize those effects, that we can do that as soon as possible to prevent any harm coming to our patients. Because face it, they're medications, and there's always the chance that that patient can experience some kind of adverse reaction, okay? It's not meant to happen, but it can happen, and we never know how an individual is going to react to a medication. So things that you learned in 123, we are going to continue to build on that, okay? So don't think that you don't have to think about things that you learned back there in the fall semester. We have drug names, chemical names, and generic names, okay? And it's very important that you know those. And we also have heard the term trade names, and that's another name for a brand names, and that's the name that the manufacturer applies to that particular drug. This is an example of a medication label, as you can see on the screen. You see what the chemical name of this drug is. It's 6-O-methyl erythromycin, and the generic name of the drug is clarithromycin, and the trade name is Biaxin, okay? And then it just talks about the National Drug Code number, and I'm not going to get into that, but I just want you to know what all those particular numbers mean when you look at the information provided on those medication labels. And it also talks about the FDA's National Drug Code. And I was very interested in some of this because I think this is great information that we need to know as nurses. That it was introduced to the drug market in October 1991 by Abbott Laboratories. It's a member of the macrolide class of antibiotics, and there are 60 film-coated tablets in each bottle. So that's what is so important about this particular medication label. And the form of the medication, that drug labels must list the form of the medication, and that they can come in many forms. And you can see that some meds, you'll see them in aerosols, tablets, capsules, cream, elixirs, emulsions, enemas, granules, injections, powders, troches, solutions, suspensions, and syrups. It's amazing the kinds of medications that we can deliver to our patients in all these various forms. This drug comes in what form? Okay, you want to ask yourself that particular question, and we know that it comes in tablet form. And also, the medication labels must list the routes of administration. The label might also warn the user about ways the drug should not be administered if it is a high-risk drug. And for example, some medications may be designed to be administered through an intramuscular injection, but not to be given IV, and that's really important to know. And it talks about the dosage strength, and that's the amount of active ingredients per dosage unit, okay? And then some medications have 2 or more active ingredients that may be present in varying amounts. For example, a drug, Lortab 5/500, contains the narcotic hydrocodone 5 milligrams and acetaminophen 500 milligrams. So that's just an example of a particular drug that you should know that it comes in these varying strengths. It talks about lot number and expiration date, and then talks about how the drug should be stored, and warnings about potentially harmful side effects, especially during pregnancy or if a woman is lactating, or other points that the manufacturer seems is essentially important to be sure the consumer is aware of. And there might be drugs provided to us in powder form, and those drugs will have directions for mixing or reconstituting. And some medications must be mixed with a diluent before administration because it needs to keep its potency. And it'll also talk about what the usual dosage of that is. And there's also package inserts. I'll let you read that. And it gives you a little bit more details than the sticker label. And you'll notice too, if you yourself personally have gotten a prescription filled at the pharmacy, they'll also provide very detailed information about the drug. Usually it's on the front of the bag that has your prescribed medication in it. And these are also, the package insert contains all this information as well. I'm just going to keep going through this, and you can read through this as well. Okay. You learned how to give oral medications in Nursing 123, obviously by solid form with tablets, capsules, and granules. We're not going to talk a lot about this in 124. It might be a question in the form of a dimensional analysis math problem, but you've already gone over this. So we're going to kind of skip through this, but it is a good way to review of what you learned in Nursing 123. So we're going to skip through this oral medication, and you're welcome to review that on your own. This would be an oral syringe, and if you had to draw up a certain amount of mLs for your patient, depending on the strength of that medication. And there's droppers. We see that a lot with children and pediatric patients as well. And there's cylindrical spoons that are calibrated in 1 milliliter increments. So these are some practice problems as well using dimensional analysis. So we're going to skip to this. I'm just kind of going through this. Now this is the section that we are providing new information with, and it's included with injected medications. And medications given by injection into veins or into tissues are said to be given by the parenteral route, because your first competency in week 3 will be on administering either an IM, sub-Q, or intradermal injection. And drugs can be injected into the skin intradermally, or we use that as abbreviated ID, subcutaneous or subcut, and muscles intramuscular or IM, or vein intravenous or IV. And we will get to IV later on, because your second checkoff in Nursing 124 will be in week 7, where you will be checked off on starting an IV. So those are the various ways in which we can give medications into the tissues. Nurses typically only perform ID, sub-Q, IM, and IV injections. Become familiar with the different types of syringes used by your facility and the markings on those syringes to reduce the risk of making a medication error. Absolutely. This first one is when you look at a hypodermic syringe, which are disposable, they have on the ends of that particular syringe a needle, and those needles can range in anywhere in length from 1/4 to 4 inches. And when you're giving intradermal, which is the way that, for instance, the man-tooth injection for assessing whether or not someone's been exposed to TB, those needles, as well as the sub-Q, because you're only going as far as the subcutaneous tissue, will require a short needle, such as a 1/4 or a 5/8 inch. Intramuscular injections use longer needles, and that would make sense because you're going deeper into the tissues to the muscle itself, and those need to be longer, anywhere from 1 inch to 3 inches, depending on the size of the person. So, and then we talk about the gauge, which is the actual diameter of the needle, from a very fine gauge, which is very small, 31 gauge, to a large, which is a 14 gauge. And you'll see that it's much, much bigger in diameter. And they usually have an orange safety cap to protect yourself against needle sticks. Okay? And then we have, after the needle, we have the barrel, and that's what actually contains the calibrated dosing scale. And it has a hub at one end and a flange at the other end. And the hub of the syringe is either a slip tip or a Lurlock design. Okay? And the barrel sling provides counter pressure of a plunger when injecting a medication. Okay? And this is what the barrel looks like. And you can see with the flanges, that's the little piece at the end of the barrel. And then you have in between from the hub are the calibrated markings. And you can see this is a 3 milliliter syringe, or a 3 cc syringe. You may see it interchanged with those terms. And you can see where 1 milliliter is, where 2 milliliters is, and where 3 milliliters is. And I'm pointing to those with the little mouse right here, okay? And then this at the top right here is what we call the hub. And this is a Lurlock, and this is just a slip-tip hub. It just depends on the type of syringe you use. And the Lurlock, it kind of locks into this, okay? Your needle. And then after the needle and the barrel, we have the plunger, and the plunger slides within the interior of the syringe. And the tip of the plunger is usually made of a black rubber-like material and has 2 rings that make contact with that interior wall of the barrel. And the ring closest to the medication is where the dosage is read. And the flange at the end of the plunger allows the nurse to manipulate the plunger without touching the sterile portion. And you'll see a picture of that. Now here is the actual plunger flange, and you can see that's what they were talking about, the top ring and the bottom ring. And here's a kind of a close-up picture of it right here, okay? And then you would read the dosage at this line right here. So it'd be right here at this top line, okay? And then we have hypodermic syringes, come in varying sizes. We have 1 milliliters, and you might hear this referred to as a tuberculin syringe, or a 3 milliliter, or a 5 or 6 milliliter. I'll have to be honest with you, I've never used a 6 milliliter. We usually use 5 milliliters. 10 milliliters are common, 20, 30, and 60. The 1 milliliter, just like I said, is also known as a tuberculin syringe, as it is used to administer the tuberculosis skin test, and it is calibrated in increments of 0.01 between the short lines and 0.1 milliliter between the dark longer lines. And this is for getting a very small, precise amount of medication. We do use this often because sometimes we can't get that precise with maybe a 3 milliliter syringe, so we would go to a tuberculin syringe. And as I said, it's used for very small, precise amounts of medication. And this is a tuberculin syringe. You can see those 0.1 milliliter increments. Shows that very nicely in this picture. And then you see the 0.05 milliliter increments, and then the whole thing is 1 milliliter. Okay, but you can see how minute these calibrations can get down to the 0.01 milliliter increments. So it gets as small as that. So it can get very, very precise. And this is just a 3 milliliter syringe, and you can see where you would, be able to how precise you can get with that, because it only has 0.5, so it'd be 0.1, 0.2, 0.3, 0.4, and 0.5. Okay, and that's a 5 milliliter. Now I'll let you go. And this is a 10 milliliter and a 20 milliliter. Okay. Now, when we were talking about sub-Q, one of the most common types of sub-Q injections would be using an insulin syringe, in which we would administer insulin to our patients. And those can either be, and we don't label those as milliliters. We label insulin as units, and it can be a U100 or U500 syringe, and this is only used for insulin, and they come in varying sizes, anywhere from 30 units to 100 units, and typically come with the needle permanently attached to the syringe. And this is how you can kind of identify that it's an insulin syringe, to be given sub-Q by that orange cap on it. You can see they're much narrower, but it also has the label of units rather than milliliters. So you have to be very careful when you're ready to give some of these medications, such as insulin, that you're choosing the correct syringe, okay? And usually those syringes will coincide with the bottle of insulin as well, okay? That you're using a U100 syringe, that you're administering U100 insulin, okay? We will talk more about insulin in week 4 when you get the information in your lecture in 122 with the pathology of diabetes. But for now, we're just kind of introducing the sub-Q injection because it could be possibly one of your checkoffs. And obviously with sub-Q, one of the most popular types of injections with sub-Q is insulin, as well as your heparin sub-Q. And then just be familiar with the syringe and the calibrations, you know, when you're determining and deciding to choose your syringe for your medication. So right now, these are some practice problems, and you can go over these on your own. What is the maximum volume that can drawn up in the syringe? And you can see that this is just a 1 milliliter, 1 cc syringe, and what value indicated is by the blue line, and that would obviously be 0.5, which would be half of the amount of medication that could be put into the syringe, and what volume is indicated by the yellow line, and that would be 0.8. And these are very typical type of questions that you're going to see on your test as well. And so the same pertains to these larger syringes. This is a 3 milliliter. So calculating dosage for medications given parentally follow the same process as calculating doses for oral liquid medications. And then medications that are injected intradermally, subcutaneously, or intramuscularly are given in small quantities due to the limited capacity of these tissues to accept fluids. Intradermal are limited to 0.1 milliliter. Sub-Qs are limited to 1 milliliter. And we only like to put about 4 to 5 milliliters of medication into a muscle, because remember, these have to be absorbed. If you calculate an answer for a particular injection site that is greater than the guidelines allows, then maybe you should recheck your math. You may not have set up your problem correctly. So here's just examples, okay? And I'm not going to go over those with you. You can do these on your own. That's why this PowerPoint is very, very nice. It kind of encompasses all the information that's presented to you in this particular chapter in your DA book. And these are all this. These are just great examples. And these will be very much like the ones, as I said, you will see on your test. So that's that chapter in dimensional analysis that you have as a way to help you understand the information and also prepare you for the test, which will be first in week 3. Okay? And I also brought up here on the screen Chapter 7 from your DA book, which again stresses the importance of safety when we're administering medications to our patient. You may want to review this one as well, talking about things that we should consider when we're giving medications to our patients. And I think this slide is very important. When we talk about medication errors, is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. Such events may be related to professional practice, healthcare products, procedures, and systems, including prescribing, order, communication, product labeling, packaging, and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and lastly, and use. There are ways that we can prevent medication errors, and it really does start with the nurse. We are the pretty much sole providers of all the meds that our patients do have ordered, and the one, and we do administer these. So it's very important that we take this responsibility very, very seriously, and that we understand that in order to minimize or prevent these medication errors, it is our responsibility to know as much as possible about the medications that we are given and the safe way in which we administer them. And I know you learned a lot about this in Nursing 123 about the importance of safe administration. So I'm just scrolling this about all the important information that we should know. So I'm not going to go over this, but I would like you to definitely review this, especially when we talk about Nurse Practice Act. I know we discussed this in Nursing 121 back in the fall, that each state does have its Nurse Practice Act that define a nurse's scope of practice and responsibilities. And as nurses, this act is designed to protect the health, safety, and welfare of the public. Okay, and each state has a Board of Nursing that defines nursing education requirements, scope of practice, and establishes disciplinary procedures for nurses who break the law. So please read this over. You want to be one that begins your nursing career by understanding your medications and by being a safe administrator of these medications. And so I really am such an advocate to be sure that people do understand what they do, and that any time that you give medications to your patient, that you are responsible for any of the outcome that occurs. So I just wanted to kind of make that point. Okay. Now what I want to talk to you about now is just the medications that were assigned to you for this week. There aren't many, there's only 5. Glargine, heparin, Mantoux TB, morphine sulfate, and your flu and your pneumonia vaccines. Along with the information in your DA book, we also want you to be responsible in learning a certain group of medications. And as I said before, your first checkoff will involve intramuscular, intradermal, or subcutaneous. And so we kind of chose meds that could be given per that route. And the first med that I want to talk about, and we're not going to go into a lot of detail with your insulins in this week, because we're going to save that for week 4 when you actually understand more about diabetes and how we help to control our patients' blood sugars. The only reason we're introducing you to an insulin called Glargine this week is because this is a type of insulin that is given subcutaneously, and this may be what you will have to do in order to demonstrate your checkoff. So Glargine is a long-acting insulin, and the important thing about Glargine is there's no peak, and it provides for steady maintenance of blood sugars. Now, your patients may not necessarily all be on Glargine. This might be a patient who is a little bit hard to control with their blood sugar. It's up and down, maybe meds could be affecting it, and maybe we would like to put them on an additional insulin to kind of get that more of a steady blood sugar, rather than that up and down effect. After they eat, it goes up, and then we give insulin, it comes down. We might put them on some Glargine to give a little bit more of steady performance or steady maintenance of their blood sugar. It also may improve their hemoglobin A1C, and you maybe don't know what that is. That's a lab test that we do on our diabetics to see how well they're in control of their blood sugar. It also helps bring down some of their lipid levels if they have elevated cholesterol or their HDLs or their LDLs. Glargine is a nice addition to their medication regimen in helping, for instance, a type 2 diabetic that has to be on insulin. It may help reduce their lipid profile, which will then reduce their risk of developing some kind of cardiovascular disease, because we know our diabetics who do have unstable blood sugars are more prone to developing cardiovascular disease, strokes, heart attacks, things like that. Usually with Glargine, it's given the same time each day. It's usually only given once a day. And there's more of a gradual notice of the action of Glargine, that it gradually starts to lower blood sugar and keep it at a steady level. Usually happens within 1 to 1.1 hours, and there is no peak with Glargine, and the effects of Glargine can last up to 24 hours. Now remember, anytime we're giving insulin, which you'll learn more about later on when we talk about all the different types of insulins, there's always a potential for a patient becoming hypoglycemic. So you want to be aware of that, especially when patients are first starting on insulin. It should always be given the same time daily, and there's no regard to meal timing. And one important nursing implication is it cannot be mixed with any other insulin. Okay, it must be given separately in a syringe. So if a patient would be on another type of syringe, you would not be able to mix that with Glargine. It has to be given by itself, and it can only be given subcutaneously. Okay? So again, always knowing a little bit about your patient and their history regarding their diabetes, knowing what their blood pressures, their labs, especially their profiles and their chemistry profiles in regards to their electrolytes, really knowing and assessing injection sites, and kind of looking at the MARS, or not necessarily the MARS, but their electronic medical record charting to determine, like, where is the trend with their blood sugars. Are they all low? Are they up and down? Do we see a steady level in their blood glucoses? I always like to know that with my diabetics. I kind of look at the last 24 or 48 hours to kind of see where their blood sugars have been running. And if I see some kind of very different value or an outlier that's very different from what their blood sugars have been running, I kind of look at that time of the day and say, why was that blood sugar so high that time, or why was that blood sugar so low? Because something must have happened to cause that blood sugar to either get so very high or to get so very low. Because when they get too high or too low, those could be some very serious diabetic emergencies that we have to tend to right away. We definitely, always watch our patients' blood sugars for other emergencies such as diabetic ketoacidosis as well. So that's kind of the most important information that I'd like you to know about Glargine. Okay? So the next one that I want to talk about, and I do have this little information screen up on the computer, as you can see for now, is heparin. Heparin's been around a long time, okay? It's an anticoagulant. It's an indirect thrombin inhibitor. And this is what we call one of those high alert medications, because heparin can have a serious effect on the clotting mechanism, because we kind of take that mechanism within our bodies without even thinking about it. But the clotting mechanism in our body is a very complex process that occurs. And when we give a med like heparin, it can interfere with that and can cause some very serious problems, especially bleeding. But the benefits of heparin definitely outweigh some of the side effects that can occur. As you can see, there's this little table that talks about the difference between heparin versus warfarin. And warfarin, another name for that is Coumadin. You may be familiar with that. The reason we're introducing heparin to you is the fact that heparin can be given sub-Q prophylactically, especially for our patients who come into the hospital. They have limited mobility, and they always have the potential to form some kind of clot. So we might give a sub-Q injection of maybe 5,000 units of heparin every 12, every 8, just depending on the size of the patient and what the healthcare provider feels is a safe dose and frequency of that medication. So this is why we're telling you a little bit about heparin. And as you can see from this little table, it activates antithrombin, which then activates thrombin and factor XA, and we can either give it IV or sub-Q. We're only interested right now, as I'm talking with this week 1 information, sub-Q. Onset is rapid and duration is brief, and there are certain lab reports that we kind of monitor to determine are we providing a safe dosage for our patients? There is an antidote for heparin, and that's what we call Prodomain, and we'll talk more about that when we get to heparin and when it's used IV, okay? What do we use heparin for? Well, of course, prophylactically, per the sub-Q route, we use it to prevent our patients from getting some kind of clot. So that's the purpose when we're administering heparin sub-Q. And I think that's probably all the information I'm going to talk about now. Now, when we give it IV, it'll be in larger doses, and that's where we might use it for a patient that has a diagnosis of pulmonary emboli or acute coronary syndrome or an MI or unstable angina, okay? And how this works is it actually activates the enzyme antithrombin 3, which in turn inhibits thrombin and activates factor V. And so high doses of this, which really we don't see a lot with the sub-Q dose, will interfere with platelet aggregation, okay? And before we begin administering heparin, even the sub-Q route, it's really important that we look at our patient's coagulation profile, meaning what are their platelets before we began this drug. Really educating your patient to be aware of any signs of visible bleeding on the skin, in the oral mucosa, through the urine, through the stools. If our patients are going to have some kind of invasive procedure, we would definitely hold the heparin 6 hours prior to that particular procedure because we wouldn't want them to have a complication of bleeding. There is a serious side effect that can occur when our patients are on heparin, and it's what we call HIT, which is heparin-induced thrombocytopenia. And thrombocytopenia has to do with platelets, meaning that the platelets are very low. And when our platelets are low, we know they're responsible for clotting, and a person could have some serious bleeding issues. So we might see this HIT or heparin-induced thrombocytopenia appear 5 to 10 days after beginning therapy. And when patients are on this for a long period of time, it may also cause osteoporosis, may cause skin lesions, and we would never give this if a person had any internal bleeding or had any evidence of severe hypertension or any recent trauma or any type of bacterial endocarditis. We also use it very cautiously in renal and hepatic patients, as it can raise labs to toxic levels. Like I said, when our patients are on sub-Q insulin, we usually don't routinely draw labs, but we only draw labs when they're on heparin IV, and that lab is what we call an APTT, okay? So we definitely want to assess the site where the heparin sub-Q injection would be, and usually we give it into the abdomen. And you will be practicing that and be instructed in how far away to give that from the umbilicus. And definitely use a short needle because we're giving it through the subcutaneous route. Okay, so that's heparin, and as you can see, we compare it with oral anticoagulant called Coumadin, and we can kind of see the difference because many times when our patients are on IV heparin for a while, they get changed over to a oral anticoagulant called warfarin, and we just wanted you to see the difference in how those drugs kind of work. Okay, please, I also advise you too that in your DA book there is a chapter on heparin administration, chapter 16, on page 319 in your DA book, in your Hornt Vet book. it would be good to go over some of that stuff. You can never know enough about heparin. It's an old drug. It's been around a long time. It's not very expensive. There are some good things that come out of it when our patients are on heparin, but we can also see some very serious potential life-threatening complications such as bleeding that may also happen. So the more you know about it, the best nurse you can be in providing safe administration of this drug. Okay? All right. The next drug I want to talk a little bit about is the Mantooth tuberculin test. It's a TB test. It's a purified protein derivative, and we use it for diagnosing TB or exposure to TB. Say, for instance, you get this test, it's given intradermally, and then you come back and have the test read within 72 hours. And a positive test doesn't necessarily mean you have TB, but it means you've been exposed to TB. And a positive test indicates the presence of memory T cells to tuberculosis, but it cannot tell the difference between an active case of tuberculosis or a latent TB. Once positive, you're always positive. No further skin tests given due to skin damage, and it's given intradermally and read 48 to 72 hours later. And positive will show reddened skin with an induration. And usually, if it is positive, your physician or healthcare provider will order further testing, such as a chest x-ray or even sputum or some other additional lab work. It's essentially a very simple test, and I'm sure you guys are aware of it because many of you had to have it as you come into nursing school. So that's the Mantooth test. And the reason we provide this drug is because it's given in one of the routes in which you will be checked off on. Okay? The next one that I want to talk about is morphine sulfate. And we know morphine sulfate is a narcotic. It's a narcotic analgesic. It's an opiate agonist. We give morphine for patients that have acute and severe pain. We use this pretty much across the board when patients come in with chest pain or they come in with an acute MI. Sometimes it's given as a pre-anesthetic sedation, calms agitated patients down. We give it for patients who have terminal illnesses. Sometimes it's administered because of patients in respiratory distress. Where we've ruled out heart failure, we might give it to patients with pulmonary edema and, of course, to our patients who have end-stage cancer. It is also given to epidural injections for post-surgical pain. We know that this is a very potent narcotic. It's usually administered or IV. CNS effects can cause dizziness, anxiety, oversedation, confusion. The big thing that we look at is any type of respiratory depression that can happen, where a patient could accumulate CO2, increase CO2 levels. We use it a lot on patients too when they're very anxious. It causes a little bit of vasodilatation, and it kind of does have a little bit of a relaxing effect as well. We know that with many of these narcotics, they can affect the GI tract and cause some severe constipation due to slowed peristalsis. We know that it can affect blood pressure because of the peripheral dilatation, so we want to make sure our patients' blood pressures are adequate enough before we administer it. It can cause some itching and rashes. Obviously, we do not recommend or have patients take this if they're drinking alcohol or any kind of skeletal muscle relaxants. And we should definitely assess the elderly when taking this because it can cause severe CNS depression and things like that. As nurses, we definitely want to get a baseline vital signs, weight, and height. INOs, and then assess pain location, intensity, and character. And obviously look at things like the CBC, liver, and renal function. And definitely assess bowel sounds and function for constipation. Maybe encourage stool softeners, increase fiber, and definitely monitor for any type of anaphylaxis or any type of allergy type related problems. Many times patients who receive these narcotics can become extremely nauseated, so many times a additional med such as an antiemetic or a nausea med may be given to the patients 30 to 60 minutes prior to taking opiates. Okay, so that's morphine. All right, and the next one I'm only going to talk about is your flu and your pneumonia vaccines. Obviously, you're familiar with this because you all had to have your flu vaccines before you participate in clinical experiences. Your flu vaccine will help protect the body against the flu, prepared with portions of the most likely type A and B flu. And it's important before giving these types of vaccines, especially the flu vaccine, to assess egg and mercury allergies and need the recombinant human DNA one. We give these usually in the deltoid IM route, and sometimes people can experience a little bit of fever, chills, and muscle aches and flu-like symptoms that maybe last 1 or 2 days, but in more of a mild form. Okay, so it's important before those are administered to assess the patient's medical history and assess any types of allergies and, of course, vital signs, and to be sure that the person does not have a fever at the time of administering the vaccine, and definitely to assess injection sites and maybe assess lab work if on any type of anticoagulants. The pneumonia vaccine is another vaccine highly recommended for people over 65 or older, or anybody between 2 and 64 with chronic illnesses or increased risk for infection, or somebody who has an immunocompromised system, like with HIV, leukemia, lymphoma, Hodgkin's, multiple myeloma, or a transplant recipient, or somebody who's been in high doses of corticosteroids. It's derived from cell walls of 23 strains of pneumonia, and it does help protect the body against pneumonia. So, again, some of the same things about allergies, just as we would do with our patients who are receiving the flu vaccine. So these, if our patients are in-house patients in the hospital, it is recommended that we look at their history to see if they receive these, because this is very important that they do. So these are the meds and some of the activities and the other additional learning that comes from your DA book. I hope this helps. Again, these prototypes are listed in your Adams book in the 6th edition, and so I'd like you to read those in a little bit more detail, because these meds and the information in your DA book will be on your first test, which is in week 3, which will come from the contents from week 1 and week 2. I wanted to provide you this because we do not have class tomorrow, because it is Martin Luther King Day, and we normally would have had class at 6 o'clock to 6:50 at night. So I'm going to put the announcement in that this video and lecture is up on Canvas, and please be sure that you view this before our second week of class, which would be the following Monday on the 27th. So have a great night, and if you have any questions, feel free to email me, and I'd be more than happy to answer you in any way I can. Thank you for your attention.